here for some question and answers. We actually have lunch on the second floor, but we'll go probably until 12:15, I think, and try to field as many questions as possible. And for those who are on Zoom, I'll restate the questions that people have. Hopefully you have a lot of ideas and questions. Yes, Dr. Stolberg. So let me restate the question. I think the question is basically, is there a role for community health workers to play as doulas during pregnancy?
Or just in general?
In non-pregnancy.
Yeah, just as accompanying during like clinic appointments. Absolutely, yes. Some of the ones that we've worked with who are embedded in our hospital system will frequently attend appointments with patients, especially in the context of the patient not wanting a family member to be there. They oftentimes will invite the community health worker in, and they, they do serve as advocates as well. So that is definitely something that is a model in community health work, to actually, be that advocate, like in an appointment, be able to, help, speak. Just imagining a doula or like even a family member coming to do that.
Thank you very much. I'm going to insert a question because, Dr. Tiro, you talked about a kind of resilient system, and actually in some ways what Dr. Arwady described is actually that parts of those system was constructed during the pandemic. Dr. Tan talked about community health workers as part of that communication system. If we build something like that, how easy is it to pivot from infectious disease to non-infectious disease issues? And then no one actually really talked about also sort of prioritization among different topics. How do we prioritize? And because we can't probably do everything.
Yeah, I can start with it. So that's where, for example, the smaller version of the contact tracers who became the vaccine ambassadors, that we're thinking of just a health response corps is what we're using broadly. But the idea of these Healthy Chicago Equity Zones is that we can't do everything, and we don't want to dictate, actually, what a particular region wants to have as its primary focus. And so the goal this has been very hard for us to write into grants, by the way, because CDC expects us to say, these folks are going to be doing diabetes. But we felt so strongly that where the secret sauce was in vaccine outreach was in not coming with an idea, but saying, here are resources, here is a framework. So I can tell you that at the health department, the 5 proximal causes, the COVID, the chronic disease, the infant mortality, the gun-related homicide, and the opioids, those are what we have chosen as our 5 proximal causes, because those drive the gap. Underneath that, though, is everything from access to housing, to education, to food, to exercise, you name it. And so my goal is not to define the focus, but to create the structure and then train folks. We've figured out very well how to kind of have ongoing training of this workforce. They have shifted. That same workforce did monkeypox for us, have done outreach to get people connected to healthcare, you name it. With very specific training, you can use that group, but I want that team working in a way that feels most relevant to that community, so it's trusted, but then also maintain some of the preparedness work so that we'll pull them in during vaccine season each year, for example.
Got it. Thank you. Dr. Tiro or Dr. Tan, did you have any?
I just wanted to add that some of the same contact tracers that she's mentioning are going to be participating in my tobacco training this week. And so, like it does, the models, like for instance, I'm working to submit a grant, with community health workers at Sinai Urban Health Institute who are involved in contact training to take their model of training and learning collaborators they use for contact tracing to apply it to tobacco or doing motivational interviewing for tobacco. Some of these are it's really understanding what the active ingredients are, particularly for training and building capacity in the workforce that really can be applied to different, either diseases or different outcomes. And then we're also working to kind of figure out what are the active ingredients in like a learning collaborative, which is where people, kind of learn from each other and kind of, touch base to discuss, cases and experiences in addition to just a standard training. And so we're really trying to understand what are the active ingredients that can be applicable across the board, not just to a specific chronic disease.
So your community health work, Dr. Tan, your talks had your community health workers were dealing with very wide range of topics, advanced care planning to tobacco. Those are really different. So your community health workers have to be able to learn quickly about new public health topics or preventive topics. What do you think? Can you tell more about training? I think there was a discussion around a training program that the 800 people you trained went through community colleges, but I think there was some mention, Marcia, that the training is different from state to state, or the certification process is different from state. What's the state of community health workers? They seem key to this whole process.
I think that what we've learned, we really want to start with the needs assessment because we really want to understand. If we know there's an 8-hour tobacco cessation facilitation training, like what do you need from that? Do you really need 8 hours? And what we've learned is that they're not trying to be the expert in whatever disease or topic. They just need the background understanding so they can continue to have this communication with their patients. So what we're learning is that they really need like an abridged, abbreviated, because they can't hold all of this information. They can't be fully trained, as experts in all of
a training program that the 800 people you trained went through community colleges, but I think there was some mention, Marcia, that the training is different from state to state, or the certification process is different from state. What's the state of community health workers? They seem key to this whole process.
I think that what we've learned, we really want to start with the needs assessment because we really want to understand. If we know there's an 8-hour tobacco cessation facilitation training, like what do you need from that? Do you really need 8 hours? And what we've learned is that they're not trying to be the expert in whatever disease or topic. They just need the background understanding so they can continue to have this communication with their patients. So we're learning is that they really need like an abridged, abbreviated, because they can't hold all of this information. They can't be fully trained, as experts in all of these things. So it's really about, maintaining their main training really is building trust, building communication skills. They get basic skills on like motivational interviewing, on being a patient advocate, like all of those things, like basic health education, how to conduct that. Then they fill in with context. So in my case, tobacco cessation, they're really interested in learning the basics of tobacco cessation and addiction to really infuse that into how they like regularly see their patients, which is ultimately to connect them to services. So like they could be providing direct services like motivational interviewing, but they also really are just trying to get them to like, overcome barriers to get them back to their appointments and things like that.
I want to get back to one of your questions about, the challenge of what we're going to do to sustain this. And I think there's just a lot of threads that are developing both on the academic side and on the public health infrastructure side that could be drawn together. On the academic side, with our large center grants, like your center, like the cancer centers, like ITM, which I still don't remember what ITM stands for because I'm still new, but I know it's called ITM, and urban health initiatives, there is this understanding of the importance of community engaged research, right? And the fact that you need kind of that engagement workforce to help. There is also these various centers, the understanding that you can't do everything because there's so much to be done, but it should be prioritized and you should be thinking through phases, right? That effort that's being done at a grant level, pushed by the federal government, can be pulled together to partner more effectively with the health equity zones that Dr. Arwady talked about, right? So how are we building our grants and our centers to build stronger ties in for where we see these hotspots when you want to focus on a particular chronic disease like cancer, so that that infrastructure can be leveraged and then we can build more sustainable things. All of these bridges can be built if we're aware that they all exist and we think through, in particular, your important point of prioritization.
I do think on the issue of infrastructure that there's a basic failure of the structure of federal financing that in my lifetime I hope will be addressed, which is that the way that we finance healthcare gives states a huge, huge incentive to prioritize personal medical services over public health. You know, if I spend, suppose I'm sitting in Springfield and I say I can spend another $1 building our public health infrastructure, or I can spend another $1 on Medicaid-funded personal health services. Well, if I spend another $1 on those Medicaid services, I get a really generous federal match, which I do not get if I spend that money on public health infrastructure, public health activities. And that is a very large disincentive for states to make these lasting investments in public health infrastructure. I'm very gratified in COVID to see huge amounts of money put in response to a crisis. That is the definition of not doing preparedness. And if we really take seriously, we need to have a public health infrastructure that is always there. We have to change the way that we finance it so that states really have an incentive to do it and keep it up, especially when, you know, we have all these things that are boring until they're not boring, and then they get boring again, and we underfund them.
Just to maybe tie those together a second, I think, first of all, on the training, the health worker training, that is one of the spaces that a lot of organizations came together around in Chicago. I always hesitate to list them because there were so many involved, but you know, that community college's infrastructure was developed with Sinai Urban Health Institute, with Partners for Health, with a lot of the groups that wanted to think about how to do this well. And I do just want to underscore this national conversation of what does it mean to be a community health worker is not a settled conversation. And I can tell you that at the local health department level, we have pushed back kind of hard federally to say, we want to create a pipeline that doesn't have an existing educational requirement, right? Like that we brought in and we've had an extremely successful core without needing a degree. That's pretty unusual, and it's not how most of the funding is going. And we've then seen those folks move on to, you know, finish associate's degrees or move on to, you know, get additional education, finish GEDs, get full-time work in healthcare. But I am a little worried that we tend to, when we're thinking pipeline, and you really want folks who are good at connecting, who can get through the education. Of course, you've got to be able to do that. But I just, for those of you who are interested in that, I would underscore that. And very quickly on the funding, I remind people in the year 2020, as in like the biggest pandemic, what percentage of the US healthcare dollar do you think went to public health? It was about $4 trillion, first year of the pandemic. What percentage went to all public health activities? 5%. 5%. And that's more than double what we will normally have. And this boom and bust funding is exactly the opposite of what we need. Like, we're really having, you know, there's folks from my team here. We're fighting very hard to, you know, we can't maintain 800 people. I want to maintain about 100 people. And it's not that clear what that funding structure looks like, you know, beyond a couple of years from now. And we have actually hundreds of millions of dollars of unspent COVID money still. But the way it was appropriated, I can't take funding that I don't need for school-based testing and use it for immunization outreach. I need money for immunization outreach. I don't have any in that bucket. I can't even move across the 35 separate lines of funding that Congress allocated for COVID, much less use those unspent dollars for monkeypox or Ebola or, God forbid, diabetes. The way we fund, we don't fund based on population. We don't fund based on sort of equity or needs of population like we do almost everything else. We wait until there's an emergency. We have a deluge of funding on parched earth of health departments, and then it all goes away a few years later. It is a disaster, and it is the biggest thing underlying our lack of ability to respond in a quick and effective way across this entire country.
Thank you. There was a question from the Zoom audience I wanted to ask, and it relates partially to what Harold was talking about, and I think Jasmin, you'll be able to talk about it coming from Texas. Clearly, not every county or city has like a Dr. Arwady or a public health department preparing for the investing for the future to address health disparities and life expectancy. And that probably relates to differences politically, differences in funding. Are we just entering an era, Harold, of increasing heterogeneity across areas of the country in terms of public health infrastructure and investment?
I'm sure others here are probably better equipped than I am to fully answer that. I think the jury is out on that, and I think we may have some ability to influence that. And I think one of the reasons why we need to be more culturally, politically competent across these boundaries is to make sure that doesn't happen. And I think we have to work in the same way that when we want to reach out to any other community of people, approach people with a sense of cultural humility and curiosity and collaborative spirit and say, okay, how do we do this so that in Texas, we can get policymakers to identify with the public health enterprise in their organic way? You know, as I mentioned, in criminal justice reform, there's some pretty impressive stuff happening in red states that was organic. It was not the way Harold Pollack would have done it, but it was the way they are doing it. And so I think that we have to embrace that mission and make sure that doesn't happen. It's hard in part because there really is a problem that there is, the Republican Party is really in moral and intellectual chaos right now. And for many of us, that's really difficult. So, but I think that's what the job is.
It's funny how different threads from your personal life come to bear on your work life, right? So this past weekend, I spent with my 8th grader studying the Constitution test, right? So how much do you understand how public health is a federal or a state responsibility and the appropriations process? Because it's understanding that and the roots of our Constitution and the 27 amendments and a 28th one we could pass about public health and the structure of how we do public health, because it affects interstate commerce. It affects, everything else that we're trying to do. That is something that we should be asking ourselves and then thinking through advocating, because the challenges of what Dr. Arwady is talking about in terms of moving things through different pots of money is all rooted in our Constitution. And this is where we should be thinking about what we're asking our legislature to do, and ways in which we could be changing our system so that it makes more sense for the current context of what we're at risk for and what we need to do to build healthier communities.
Yeah, I couldn't agree more. And just to put a very specific point on this, almost always cities are where infectious diseases tend to emerge. We have more density, we have public transportation, we have more international travelers, domestic travelers, commuters. We have typically the larger hospitals that are the referral hospitals, diagnostics, whatever. And you've got to be able to contain an outbreak wherever it starts, whether that is a rural area or a urban area. But the way that we fund right now, if you make the analogy to terrorism, right, we just wait until there's an attack and then fund sort of after the attack for a short portion. And for terror, the challenge is that as this has become more and more politicized, we have seen states, some red states, basically say, we're done with COVID. I'm not going to name the state, but we don't want this COVID money, which means that the city, my counterpart, has zero money to do vaccine distribution, and and so to try to solve this, it all goes back to appropriations. But the CDC, for example, historically funded about 60 jurisdictions, the 50 states, 5 or so territories, and then directly funded 5 large cities. So Chicago gets direct funding, and that makes us somewhat more nimble. But because of how politicized in some cases this has become, CDC has made a decision to, instead of directly fund 5 cities or local jurisdictions, they're going to fund about 50. That's great in theory, but do you know what that means for Chicago? We're getting 10% of the funding that we would have been getting, because the same amount of funding is being divided among local organizations. So there's this problem that as you work to kind of solve the issues, if we do not get the politics out of this and fund, we don't fund transportation based on what the politics are in an area. We fund based on population, need, and sort of evidence based. But that, for whatever reason, public health gets caught in the politics and gets caught around specific diseases, and it will not work. It's gotten worse during COVID.
Thank you. So it does tie back to politics and the Constitution. And how we planned or didn't plan for public health. And Dr. Vollerman, you had, I think, probably you had a question.
Thanks, Elbert. I'm Anna Vollerman. I'm a internal medicine and pediatrics primary care doctor here and a health services researcher. I'm struck by the conversations today and also in other work that I've done with community health workers, that oftentimes the efforts of community health workers by a particular disease, right? So these community health workers are going to focus on asthma. These are going to focus on vaccines, et cetera, or they're going to focus on cancer. The reality is most of my patients don't just live one disease and don't just think about their health in these very predefined ways. And it's led me to reflect a little bit about how that's come about. And I wonder if it's related to the way that community health workers are currently funded, because grants are often disease oriented. And so I guess, what are the opportunities to move beyond that? And I know that there's, systems or processes moving forward to support reimbursements within the health system. And so hopefully that will help. But how do we start to think about that infrastructure now in terms of both training the community health workers, how they do their work? Is it by neighborhoods rather than by diseases, et cetera? And then how do we ensure that they're integrated with the healthcare team and all the IT systems and the communication systems that might exist otherwise?
So just a couple things locally on that. One, I think, is right at the beginning, I talked about we fund diseases and we fund cases and containment. We do not fund coordination and communication. And thinking about how we fund those core activities, that is where these folks fit in. That is where the training is. And there are real deliverables you can have on this. I also think we are standing up as a result of COVID. I don't know if this room knows this, but for the first time, Chicago is finally going to have a 211 system. Most of the country, you can call 211. It's a single number and someone will connect you to your health and social service needs. We're the only big city that doesn't have it. And it's one of the sort of newer investments of this idea of saying, and it's in part growing out of what we've learned from having the contact tracers and sort of seeing how do you combine a phone number with outreach navigators. It's not just waiting for people to come in, but it's about having folks going out. So we are trying to think about how to create the structures that live behind people who are out trying to reach people wherever they are. But you are right that almost all funding comes tied to a disease. And that makes it very challenging to create these structures that we need.
Yes, I agree that the funding by chronic disease is very challenging, because that's often what you see. Like a lot of community health workers are hired under grants for that particular time to do whatever intervention. I think, and that's part of my research program, is really to understand how to develop something that is that you can, a basic skills-based training that you can insert different content area into. And right now I'm working on just general motivational interviewing, but the idea that, the goal is really to help the community health worker get the patient's behavior aligned with whatever their goals are, whatever that may be. And so I'm really trying to think about how to train to develop skills that could be applicable across, diseases and kind of dependent on the patient, and to kind of teach them how to intervene very flexibly in the way that makes sense for their patient, how they care for their patients.
Thank you all. So unfortunately, we've run out of time, but we've had a great morning. I want to thank all of our speakers. I want to thank Mary King. I don't know if she's in here, who was really the architect behind the entire symposium, and many of you have interacted with her during registration. But the conversation can continue upstairs at lunch. There's posters as well. I think I can come away with this with a lot of excitement about all the things that have been constructed, all the things that we've learned during COVID-19, that we could, if we can figure out how to pivot to, we could really help a lot of people. So thank you very much, everyone, for coming. I'm sorry, did you want to make an announcement? Yes.
So a couple of things I wanted to say. I think often the way that one of the questions I always pose, and I started doing this before COVID, and I certainly continued and will continue to do so, is asking the person in front of me, and I think you'll know this too, right? Is what is the biggest thing concerning you right now? Because that is often not related to the health problem that they're going into that appointment for. And that's often the barrier that then I can step in to try to solve to get them to take better care of their health. Because if they're not doing well at home, they're certainly not going to focus about their chronic health conditions. And the other thing I wanted to say is that it was a really wonderful fresh breath of air hearing you speak about that polarization and the lack of diversity that we see in different points of views, right? There's so much focus on having diversity when it comes to our color of our skin or the box that we check on a form, but there's no diversity of thought and opinions or diversity of different experiences, right? And that's not really complete public health then. We're not really talking about the things that communities talk about, but often don't feel comfortable enough talking in a elite or academic setting. And so there's this just same sort of ideas, with the people that agree with you. And so how do you fix an issue, right? Because if you, just like in a couple, when you go to bed, Ingrid and I both on your side of the bed, seething, that's not going to solve the issue, right? You have to talk to each other to get forward. And it's the same way. And I'm so glad to hear you say that's something that we have to do if we're truly invested in public health, and keeping that empathy for all of us, regardless of whether I agree with you or not politically. At the end, it's our human worth that matters. So thank you.
Thank you. Thank you panelists and speakers. All right.